Hello everyone and welcome again. So continuing our discussion about the orthopedics trauma basic principles class. Now we are going to talk about the management of closed fractures. You know that this is one of the more important topics in this class because most of the times your patient is going to present to you with a closed fracture. So you need to know the steps for treating this patient. And this is going to be explained in this video. So let's start. So we will start by mentioning the outlines of the emergency management, and then we will talk about the reduction, which is on two types, closed and open. Then we are going to talk about the holding reduction methods, and those include the traction, the cast splintage, the functional bracing, the internal fixation and the external fixation, and finally we will talk about exercising the joints. So let's start by talking about the emergency management. So when the patient first reaches the hospital, you need to use the advanced trauma life support trauma protocol to stabilize the patient. And this protocol is explained in one of the previous videos in this series. It is called the Emergency Management of Trauma Patient ATLS protocol. The second step is that you take full history and examination of the injuries. So you take full history from the patient and you examine all the injuries that he had sustained. And after that, you focus on the fractures. And if the patient has closed fractures, then you treat them by first reducing the fracture, then holding the reduction by one method, and then exercising the joints. So let's talk about the principles of treatment of closed fractures, which we already mentioned: the reduction, the holding the reduction, and the exercise. So the reduction is that you reduce the fracture, meaning you manipulate the fragments to reach the normal anatomical position. The holding the reduction literally is that you hold the reduction in its position so it stays the same as the fracture heals. It's also called retaining reduction, and it means holding the fragments together until they unite. Most of the times it is only called holding, but the name for it is holding reduction, also called retaining reduction, but most of the time it's going to be referred to as holding. And the final step is the exercise of the joints proximal and distal to the injury to get the patient back to normal function. So let's start by talking about the reduction. So reduction, it means that you return the fracture fragments to their normal anatomical position as we mentioned. This procedure comes after stabilizing the patient. So it comes after applying the ATLS trauma protocol on the patient. Swelling of the soft tissue in the first 12 hours after the injury make the reduction difficult. Also, during reduction, you should aim for adequate apposition and normal alignment of the bone fragments so the bone heals well. The greater the contact surface area between the fragments, the more likely healing is to occur. Some overlap at the fracture surfaces is okay as long as the fracture is in location other than the articular surface. The articular surface fractures should be reduced as near to perfection as possible because any irregularity might lead to abnormal load distribution and predispose to degenerative changes at the joint, meaning it leads to osteoarthritis in the long term. So here I will mention some situations in which the reduction is unnecessary. So reduction unnecessary when there is little or no displacement at the fracture site, and when displacement doesn't matter initially, example in clavicle fractures, and when reduction is unlikely to succeed, example in vertebral compression fractures. We have two types of reduction. We have the closed reduction and the open reduction. The difference between them is that in the open reduction is that you take the patient to the operating theater and open the skin and reduce the fracture under direct vision, while in closed reduction you only reduce either by traction or manipulation, and both of those you don't need to open the skin. So let's start with the closed reduction. So the patient is given analgesia, local anesthesia, or general anesthesia, depending on the situation, for pain and muscle relaxation to occur, and then reduction is done either through manipulation or through traction. Manipulation is done through these three steps. The distal part of the limb is pulled in the line of the bone. As the fragments disengage, they are repositioned by applying force that is opposite to the force caused the fracture, and then alignment is then adjusted in each plane. The other method is the traction, in which the fracture is reduced through ligamentotaxis, meaning ligament pulling, which is applicable to specific fractures. The traction is going to be explained a little bit later in this video. So closed reduction is most effective when the periosteum and the muscle on one side of the fracture remain intact, meaning the fracture is stable, preventing over-reduction and stabilize the fracture after reduction. Some fractures are difficult to reduce due to powerful muscle pull, so prolonged traction is needed. Closed reduction is mostly adequate for all minimally displaced fractures. Closed reduction is used for unstable fractures in emergency settings to be fixated at later times in theater. And the closed reduction fails because either it is difficult to control the fracture fragments, or the fracture fragments are stuck because the soft tissue is interposed between them. And when the closed reduction fails, you need to do an open reduction to the patient. So what is the open reduction? It means operative opening of the fracture site and reduction under direct vision. Indications of the open reduction is that when a closed reduction fails, as we mentioned, when it is an articular fracture that can't be reduced accurately when closed, and for avulsion fractures, because avulsed fragments is connected to a muscle that continuously pulls it away. So you have to openly reduce the fragments and stabilize them using internal or external fixation. Now we will talk about the second step after the reduction, and that is the retaining reduction, or also called the holding reduction. This is the second step, as we mentioned. It's previously called immobilization, but the term is not used anymore because it is rarely complete immobility. In most cases, there is still little movements, micro movements at the fracture site, and those are good for healing to occur. So it means that you hold the fracture in place until healing occurs. And you need a form of stabilization to the fracture site that hold it in place while the patient is able to exercise the joints, proximal and distal to it. Holding reduction is achieved using various closed and open methods. The closed methods being the continuous traction, the cast splintage, and the functional bracing. The open holding methods include the internal and the external fixation. Closed holding methods are more suitable for fractures with intact soft tissue and muscles, because intact muscles and soft tissue act as support to the fracture with the holding method used, while the open holding methods used in fractures with severe soft tissue damage, unstable fractures, multiple fractures, fractures in non-cooperative patient, and if we use open reduction for the fractures, we have to also use open holding method because we already open the skin. So when we reduce, we have to use an open holding method for the patient. Next, we will talk about the types of the holding methods. Let's start by talking about the continuous traction. So continuous traction is mostly used as a reduction method nowadays, as we mentioned in the closed reduction, and it is used as a holding method only as a bridging procedure to relieve pain and reduce the fracture until the patient reaches operating room for open holding method to be applied. Normally, muscles attached proximal and distal to the fracture site will pull the fragments towards each other and displace the fracture. And the idea behind traction is that you counter the muscle pulling by pulling the limb the opposite side. So let's say we have a femoral shaft fracture right here, and we all know that there is muscles coming up and attaching down, and those muscles will exert a force that they pull the distal fragment, which is this one, towards proximally, so towards this side. That's the muscle pull. This will make the fragment hurting the soft tissues here and also here, leading to patient being in pain and also leading to the vessels and nerves maybe being injured. So the idea of traction is that we apply a force that is opposite to the muscle pull, force this way, and we try to pull the bone away, opposite to the muscle effect, and this would relieve the pain, relieve the and prevent the injuries also, and that's the idea behind traction. So that's why traction is applied to the distal part of the limb to pull it away from the fracture site, thus countering the muscle pulling. Of course, once you are pulling the distal part, you need some stabilization to the patient body so it doesn't get all pulled. Traction is useful for shaft fractures because they are highly affected by muscle pulling, especially oblique and spiral fractures that are easily displaced by the muscle contraction. It can also be used for acetabular fractures with femoral head subluxation or dislocation. Traction cannot hold a fracture still. It can pull a long bone and hold it out to length, but to maintain accurate reduction, it is difficult. And that is why nowadays traction is used as a bridging procedure to reduce the fracture and relieve pain until the operation is done to the patient for internal or external fixation to be applied to the fracture. Traction includes three methods: traction by gravity, skin traction, and skeletal traction. And let's start with the traction by gravity. So this applied to upper limb injuries only, mostly humeral shaft fractures. The wrist sling, the U-slab, is applied and it provides a continuous traction using the weight of the arm to pull it downward. So this is the U-slab. It applied to the wrist and it would the gravity would pull the arm downward, and this would lead to reduction of the humeral shaft fractures and it would hold it in place. Skin traction is used for lower limbs mostly. It allows of traction a weight of no more than 4 to 5 kilograms, which is equal to about 10 pounds. Holland strapping or one-way stretch elastoplast are applied to shaved skin and held on with bandages and connected to a weight. This is the old image of skin traction applied to the patient leg. Skeletal traction, on the other hand, is that there is a pin inserted usually behind the tibial tuberosity and connected to weight for hip, thigh, and knee injuries, or through the calcaneum for tibial injuries. So it is either through the tibial tuberosity or through the calcaneum, depending if it is a hip, thigh, or knee injury or for tibial fractures. And this is a picture of that. Complications of traction include skin irritation, pressure sores, discomfort or pain, circulation compromise, and that's why you need to check pulses after applying the traction. Nerve injury, especially with the skeletal traction, the common peroneal nerve injury, which lead to foot drop, and the pin site infection with skeletal traction. When you apply the pin, the site that you apply to it might get infected. So we talked about the continuous traction. Now we talk about the cast splintage, which is also a closed holding method. And this is the most common holding method that is used. Plaster of Paris is the mostly used material for casting in emergency department because it is versatile, easy to handle, and strong, but the downside with it that it is heavy. Other materials like fiberglass or polypropylene are lighter and used for definitive casting, but they are harder to handle. Casting is used either to create a split cast, which is a back slab, or a full cast, and we will talk about each of those. So the back slabs. It is a split cast applied to one side of the injured limb to act as a splint. Split cast means that it is not a full circle. It is basically a half circle or less than that is applied to the limb. The casting material used in slabs is several layers thick, and it's mostly a plaster of Paris, and it doesn't allow 3-point fixation, thus provides less fracture support in comparison to the full cast. It is used in emergency settings only. It allows swelling of the limb in comparison with the full cast that it limits the limb to swell, and it is easily applied and easily removed with a scissor only. The back slab types, we have the U slab that we talk about in the continuous traction. It provides continuous traction in humeral shaft fractures. The above elbow slab, it is used for distal humeral fractures, elbow dislocations, and forearm fractures. And the wrist slab that is used for distal radius and scaphoid fractures. And we have the volar hand slab that's for metacarpal and phalangeal fractures. Make sure to search every one of them just to see a picture of them so you have an idea about it. The thumb spica is for base of the thumb fracture and first metacarpophalangeal joint injury. The above knee slab is for the tibial plateau fractures, tibial shaft fractures, and knee dislocations. And the below knee slab is for ankle fractures and foot injuries. The full cast, on the other hand, the casting material is in a full circle around the limb to provide support. The layers is built up one on another until the cast gets the desired strength. The full cast can be molded to shape allowing a 3-point fixation and provide better fracture support than a back slab. So basically, if this is the bone, the full cast would be like that. It would provide a 3-point fixation to the fracture. The full cast require more experience. It is harder to remove in the event of swelling and circulatory compromise. So if you expect the limb to swell, then don't apply it until swelling subsides or apply it with thick padding. So basically you apply the back slab first, and once the swelling go away, then you can apply the full cast. You have to wait for it. Casting technique starts with that after reduction of the fracture, the preparation of the materials and equipment, then padding with cotton or synthetic materials applied to the skin and bony prominences, then application of plaster of Paris or any other casting material is done. After that, you wait for it to dry and harden, usually about 15 to 30 minutes, and finally you follow it up. That's watching for swelling if casting is done as emergency. Disadvantages of casting include is that the joints included in the cast can't move and liable to stiffness. The articular fractures need movement for the articular cartilage to heal, but with casting the articular fractures can't move. Tight cast, that the cast may be put tightly or become tight after swelling. The patient complains of pain and you check the vascular compromise, and then you do splitting for the cast and ease it open through its length and through padding. If swelling is anticipated, thick padding is used and plaster splitted before it sets. Loose casts is that after swelling subsides, the cast becomes loose and thus should be replaced. Pressure sores is a classic disadvantage, is that especially in the bony prominences, the patient complains of localized pain on the pressure spot, and you make a window through the cast and inspect the pain site. Skin abrasions and lacerations, it is a complication of removing the cast, especially if the electric saw is used. Now let's talk about the third closed holding method technique, and that is the functional bracing. It is a closed holding method, as we mentioned, and it is the same as the cast, but device that is used to stabilize the fracture, again same as the cast, but it is already made and has many variations depending on the bone, and that is broken. So it's basically an already made cast from different materials, of course. It is more convenient than a cast because it is already made, and functional means the patient can resume normal movements but while using it. There is also other types of braces like rehabilitative braces and prophylactic braces, but functional is what we use in fractures. A bracing is also referred to as orthosis. It allows the patient to adjust tightness of the device, remove it and wash it, and if used in lower limbs, then allows walking better than a cast because it is very light. It is used for stable injuries and after surgical stabilization of fractures, and examples: the moon boots, the hinged braces, the wrist splints, and the mallet splints. On the right side here, we have a knee bracing, as we can see here, and also here we have an ankle orthosis or ankle brace that's used for the patient with a foot drop to hold the foot in place, prevent it to drop. We have a lot of different braces. We have for the wrist, we have for the back, and other types. Now let's talk about the open holding methods, and those being the internal and the external fixation, and let's start with the internal fixation. So it's an open holding method as we mentioned. The internal mean is that all the devices used to fixate and stabilize the fracture are inside, and nothing is popping out of the skin. In internal fixation, the implants of various types is used depending on the situation. They include screws, plates, tension pad wires, and intramedullary nails. Indications of internal fixation include is that in fractures that can't be reduced by closed reduction, because once you use open reduction, it is obligatory to use an open holding method, which is either internal or external fixation. It is also used in unstable fractures that are prone to displace after reduction, and it is used in avulsion fractures. It is also used in pathological fractures because bone healing is impaired, and in multiple fractures where early fixation reduces risk of general complications. It is used in fractures in patients who present nursing difficulties, example the paraplegic patients and the very elderly. So let's talk about some orthopedics implants, and let's start with the screws. The screw is a device that converts rotational force into compressive one to hold the bone fragments together. It contains head and shaft. So this is the head and this is the shaft. The head has a socket which can accommodate a screwdriver. The shaft has a core and thread. So this is the core of the shaft, and those are the threads as you can see them here. The separation distance between the threads is called the pitch, which equals the distance the screw travels when turned 360 degrees. So the distance between the threads being this distance is called the pitch, and when you turn the screwdriver 360 degrees, it moves by about this space. We have a lot of different types of the screws. We have according to the shape, and those being the cortical screws and the cancellous screws. The cortical screws has a small diameter and pitch suitable for stabilizing the dense cortical bones. And this picture here contains different types of the cortical screws. The difference is that they have a small pitch, and they have also different types, maybe fully threaded like this one, even threads in the head, or partially threaded like this one. The cancellous screws, on the other hand, has larger diameter and pitch, which provide better grip in more porous cancellous bones. So they are used in more porous cancellous bones, the cancellous screws, and those are examples for them. So basically they have a bigger pitch, and they have bigger threads overall, and they would have better grip in more porous cancellous bones in comparison to the cortical screws. The locking screws are used with locking plates and have threads in their heads. So this is an example of a locking screw. It has threads in its head, but this is also a cortical screw. So it is a locking cortical screw. The lock screws is used to compress fragments together. This is an X-ray of the 5th metatarsal fracture, as we can see here, and is stabilized by 2 screws. This is a picture of an X-ray of a tibial plateau fracture, and is stabilized by 2 cancellous screws, one of them being partially threaded, as we can see here. Now let's talk about the plates. The plates are devices applied to the exterior part of the bone to maintain alignment and reduction during bone healing. This device is held by screws. And this is the device here. It has many shapes depending on the fracture, and it has also different functions, including neutralization protection plate that is used with lock screws to control torsional forces between the bone fragments. And we have the compression plate that is used to compress 2 bone fragments together and used for diaphyseal fractures. We have the buttress plate that's used to resist shear forces, especially in metaphyseal fractures. And we have the bridging plate, bridges simple or multifragmentary fractures to restore the correct length, axis, and rotation. This is an example of fracture of the fibula and the medial malleolus. That is, the fibular fracture is being fixated by a plate and screws, and the medial malleolus being stabilized with 2 lock screws. We also have the tension band wire. It is a metallic wire that is used in case of the fracture fragments are too fragile to be fixed with plating. Examples in olecranon fractures, the medial malleolus fractures, and in the patella fractures. This is an example of a patella fracture that is stabilized with a K-wire or a tension band wire. This is the tension band wire here. And we also have the intramedullary nails. Those are long rods inserted in medullary bone canal. That is why they are called intramedullary. They are the standard of care for diaphyseal bone fractures of the lower limb. They mostly for the femoral shaft fractures. Rotational forces resisted by adding interlocking screws to the nail. So this is here, we have the nail here, and here we have the interlocking screws applied. So here we have an X-ray for a patient with a right femoral shaft fracture, as we can see here. They have their left shaft is already stabilized with a rod, as we can see here. This is the picture of a 3D CT scan model, and it is here stabilized with an intramedullary nail. So they have now both of their shafts are stabilized with nails. Complications of internal fixation. We have the infection being the most serious, and it is mostly iatrogenic because orthopedics implants increase the risk of infection. Infection lead to chronic osteomyelitis most of the times. Non-union, that is when there is a gap between the fixed bones or there is damage to the blood supply during the fixation process. So non-union is either occur because of the gap or because of the blood supply, and also occur because of the infection. Implant failure, if the device not capable of supporting the full load transferred through the limb. And refracture, that's when the implant removed sooner than a year. The safe removal should be after 18 to 24 months. Now let's talk about the external fixation. So it's an open holding method, surgical method. External meaning that parts of the devices used to fixate and stabilize the fracture are popping out of the skin. And we use the external fixator device in the external fixation. Types of external fixation include uniplanar, multiplanar, unilateral, bilateral, and circular. And this is achieved using the fixator device, which held by pins and wires. Here we have an example of a distal radius fracture here, and it is held by wires, tension band wires, as we can see here, and it's also held by an external fixator device. This is the device, and it is held by pins, as we can see here, and also pins here. And this is the image of the patient arm while the fixator is applied. Indications of external fixation include temporary stabilization of the fracture in cases of the severe soft tissue damage, including open fractures, to allow for redebridement. So basically, when there is an open fracture and there's severe soft tissue damage, we use external fixation so we can reopen the site for redebridement. Extensive contamination, where internal fixation is risky because it would lead to infection, so that's why we use external fixation. Patient with severe multiple injuries, chest, abdomen, head, or with multiple fractures, we use external fixation for them. Fractures around the joints, where the soft tissue is swollen and internal fixation is risky. Bone lengthening techniques, and infected fractures. Complications of external fixation, it leads to damage to soft tissue structures, example nerves, vessels, ligaments. Non-union, because if there's a gap between the fragments, and pin track infection. The final part of the fracture management, the closed fracture management, is the exercise, because remember we start with the reduction, then we hold the reduction, and finally we exercise. So the exercise is that restoring function of the injured limb and the patient as a whole. Exercising leads to reduction of the edema, preserve joint movements, restore muscle power, and guide patient back to normal activity. The holding reduction method should allow the patient to fully use of the affected limb immediately after the procedure, but in practice that is not always the case. Certain injuries require limiting function to avoid displacement during healing, movement restriction, prolonged hospital stay, and lead to joint stiffness on the long term, so it is better to exercise the joints. Patient encouraged to actively exercise their joints. This would help pumping away the edema, stimulate circulation, prevents of tissue adhesions, and promotes fracture healing. If the limb is encased in plaster of Paris, then static muscle contraction is taught to the patient. After removing the splints, then joint mobilized. The unaffected joints should be exercised too, because remember, those if left without exercise, they would also stiffen, so it is they had to be exercised too. Assisted movements, the other type, we have active movements and assisted movements. This is with gentle assistant for the patient. And with that, we reach the end of this video. Thank you guys for watching. Please make sure to like and subscribe. And if you want to support more, you can by subscribing to the Patreon, link provided in the description of this page. Thank you for watching and peace.